This is Judy Felter lecturing on Chapter 31, Serious Mental Illness. And this chapter is written with focus on people who suffer from chronic or recurrent mental health conditions. Conditions such as depression, schizophrenia, bipolar, manic, depressive type of patients. The student needs to understand that people with seriously mental illness suffer from a lot of challenges in their personal lives. Some people live lives parallel to lives that everybody else lives, meaning that they may live in one reality with one set of living conditions, while others live in the normal world. The problems with the seriously mentally ill are getting services to them and keeping them well and empowering them to be healthcare consumers that are able to move forward and to recover, the model of recovery. The first part of your chapter deals with just describing how we used to institutionalize people, and that group of people who are seriously mentally ill, when they were deinstitutionalized, are more passive consumers of care. They were used to being told what to do, when to do it, how to do it, and they have special needs. And then the younger groups of people who did not and were not institutionalized, they have problems with being admitted in acute care facilities and then turned out and readmitted and turned out and readmitted and turned out, therefore never enjoying or having a full recovery or some kind of stabilization in their life. They have very, very many challenges, and therefore we see them on a continual basis using many of our resources. When you go to Osawatomie, will be dealing with primarily the seriously mentally ill, and it will become fascinating to you to see how these people live to be, a certain age, suffering from such catastrophic illnesses. One of the very major points in our culture happened when we decided to put the mentally ill patient in the driver's seat, and this was done through legislation and through action by families and loved ones who have patients who are seriously mentally ill. NAMI, the National Alliance on Mental Illness, is an advocacy group for families and consumers of services for the mentally ill. We have changed the idea that these people are to suffer continually without any end, all of the consequences of their illness. Rather, we want to involve them in a recovery process. So now we are looking at the recovery model of care for these people. We are emphasizing that they are consumers of care, that we need to empower them and give them hope, that there's a future, there's stability, that we will focus on their strengths and not their disability, and encourage them to become independent and allow them to have goals and hopefully achieve those goals through a lot of community support. Confronting issues that confront mentally ill people. There are different topics or different highlights in your book. It talks about physical disorders, those being things that mentally ill patients suffer with, as well as mental illness. One example might be that they are on some kind of medications, and that may lead to other problems. Another thing that your book points out is the victimization of the mentally ill. The book points out that people with a serious mental illness die 25 years earlier than other people would normally live. The second one is depression and suicide. People with seriously mentally ill find it hard not to be hopeless, and they also they may succumb to depression and attempt and complete suicide. Substance abuse, again, 60% of those with serious mental illness, not all mentally ill, but those who are seriously mentally ill, they suffer from the use of other substances to treat their mental illness. Stigma is a big factor in our society. I feel like it's gotten a lot better than it used to be for mental illness. Just basically, what a seriously mentally ill person should look like or act like, and should we be scared of them and what they're capable of. And that's all kinds of stigma for people who are seriously mentally ill. Isolation and loneliness. When seriously mentally ill people cannot socialize and function as normal people do, they tend to withdraw from the groups of people or developing any kind of relationships. Think of your Erikson stages. Think about, the young adults with seriously mental illness and the task of developing those relationships and completing relationships outside of their families. And if they're unable to do that, then it just perpetuates from their difficulties with being mentally ill and being able to be self-sufficient. Victimization, they are more likely to be victims of crime rather than to perpetrate crime on other people. I want to go back to physical disorders as well. Just keep in mind that a lot of seriously mentally ill may not be able to express or explain signs and symptoms, and healthcare providers might not be able to understand the problem, physical problem they're having, and assume that the patient is, is part of their mental illness, and that is part of the problem with the comorbid conditions. Economic challenges, not being able to work, and therefore being poor, housing instability, not being able to afford housing, but also not being able to act appropriately, take care of housing, puts them at risk for not being housed. Then we go into caregiver burden. If you think of the client that we had met this past week, who had family support, but had all kinds of things that happened in her personal history that kept it from being a healthy situation. Those kinds of problems, but as well as people who are, the resources for their families might not be there. People who are chronically mentally ill require a lot of care, a lot of support, a lot of patience. If you can only imagine somebody with a mania, not being able to sleep properly, or would disturb a household, not be safe, to be let out until their mania is controlled. Someone with schizophrenia who might have some delusions or hallucinations, some paranoia, making it difficult for others to care for them. This all wears on the family, coupled with, parents or older siblings getting to the age where they can no longer care for someone who's chronically mentally ill. So that's a concern. Treatment issues. People who are chronically mentally ill have adherence problems to their medications. Part of it is what they describe as anosognosia, and what this is they have lack of insight that they are ill. It's not necessarily denial, but it's the inability to understand that they are seriously ill. This is a problem. Your book has a great box about non-adherence suggestions for the nurses, medicines that will be effective without the least amount of side effects, decreasing the number of times a person has to take medication, making sure that the person is taking their medication. You can do this by just helping them with psychoeducation groups about their illness and the meds and the need to take those medications, following the treatment and making sure that you're keeping an eye on side effects for the different patients. Being culturally sensitive, again, that's a big issue with our mentally ill people as our culture changes and our society makeup changes. Don't be judgmental. When someone is not adherent to treatment, there could be a very good reason. If they don't have the insight to be taking their medications, perhaps that's because the reason they're not taking them, and then therefore you have to figure out a different way to go about doing that. Long-acting, long-sustained release medicines are very good for patients who have problems with this. Medication side effects, especially antipsychotics, either the muscle tremors, which we'll get into as we get into those, or the risk for diabetes, heart disease, hypertension, weight gain, all those things are catastrophic to the people who are mentally ill taking medications for that. Treatment inadequacy. Again, your book points out NAMI, which is, like I said, an advocate group for those who are consuming mental health services, as well as families and friends of those and loved ones of those. State by state, they did an evaluation. You can get it at the NAMI website, and gave each state a grade on how well the mentally ill are served in our society, and the results were not good, but we're trying. We keep trying. Other symptoms. When patients don't fully recover and they have residual symptoms, perhaps someone who has some hallucinations or a little bit of paranoia, and they're not completely taken care of. Those positive symptoms aren't completely taken care of by those medicine. Relapse, chronicity, and loss. It always boggles my mind that we expect people who do not have normal brain function to be able to take medicines and to cope with day-to-day life when we ourselves have a trouble coping with what comes our way from time to time. So they really have a challenge to utilize an organ that's dysfunctioning in their body or is dysfunctional to deal with everyday life. So if you can think of it that way, I think that will help you going into Osawatomie. It goes into resources for the persons with serious mental illness. You know, you can either treat the patient with community resources and try to get them to recovery and in some kind of stable situation, or you can deal with the catastrophic effects of being seriously mentally ill. It's up to you. And I would advocate rather to assist those with serious mental illness, especially because the majority of them are not harmful to other people, to be able to help care for those people through community-based programs. They give you different scenarios for community therapy. The overall goal, they say, of community psychiatric treatment is to improve the community's ability to function independently and achieve a satisfying quality of life. So we want those people to have some kind of quality of life. And I think as compassionate caregivers, we want that for all of our patients, including the seriously mentally ill. And then it goes in to describe different treatment programs, and I'm going to review those for you. Psychiatric and medical somatic services. These are looking at the biological aspects of those. That would be like a community mental health center where you would go and you would get your psychiatric needs met. They are also, as we've discussed, setting up treatment for physical needs as well, and I think that that's probably the best thing, is when we can one-stop shop. Case management, I think the majority of you students would realize what case management is. It's someone who is managing the care of the patient, be it with referrals or services and trying to coordinate those services, or perhaps some kind of medication management. Lisa Nix is one of those nurses at Crawford County Mental Health Clinic, and I do have a video. Perhaps we can get to that before the end of the semester in some way, but she's phenomenal. She does medication management for chronically mentally ill here in Crawford County. Day programs, that is that the patient would come during the day, they would get some kind of group or psychoeducation from the program, social skills training, that would stabilize them and help them to function better in the in the community. Crisis intervention services, that would be like if we had a crisis hotline, or if we had a place that we could go or to be evaluated if we had a crisis. They do give you the 4 steps to clarify the situation, build on the patient's strengths and support system, identify realistic step-by-step goals, and promote problem-solving skills. The next one is emergency psychiatric services. Again, this has to do with, like the emergency room. They also talk about mobile crisis teams. You can even think of that as, perhaps when we have the mass shootings, where we have those mobile teams go into the communities or go into the situations in which people find themselves in a crisis situation for psychiatric, psychological concerns. Group and individual therapy, family therapy, psychoeducation groups. So family therapy, helping the family understand what the mental illness is and how to cope with that with their family and be supportive. Psychoeducation, meaning, do I understand my disease process? Do I understand maybe some coping mechanisms that I need? Do I understand my medication? Why do I take my medication? Support groups, you can think of those as people with the same illness supporting each other, just like if someone had a grief support group, or just like if someone had open heart surgery and they have heart groups for that, or COPD or whatever. Well, these are groups concentrated predominantly on people who have serious mental illness. It could be the same illness, or maybe a different or a combination of illnesses that they would get together, and they would help one another with their problems. They talk about the other approaches: cognitive therapy, cognitive behavioral therapy, and supportive psychotherapy. Cognitive therapy, being able to understand what your illness is and go about that to deal with that. Cognitive behavioral therapy talks about capturing those negative self-thoughts and reflecting on them and turning them into the positive thoughts. And supportive psychotherapy would be for someone who needs to has a particular situation perhaps, and they need to see a psychologist or a psychiatrist to explore that particular issue and to work on an issue with an individual. Housing services, group homes versus independent living situations. Perhaps a case manager or social worker would come and check on those individuals. You have those scattered through all of your communities, even though you're not aware of that. Even groups of whole apartment complexes just geared to the chronically seriously mentally ill. Partial hospitalization programs, you'll see that discussed at Osawatomie, where people are getting well, they are recovering, and then they will move them to an area where they care for themselves, even giving themselves their own medications and trying to see if they can function with their activities of daily living, independent activities of daily living, so that they can move through. Think of it as like if you were on a rehab unit and you couldn't walk very well, and so we went there to get stronger with OT, speech path, PT type services. Same thing, only here we are just trying to move through the stresses of living on your own, taking care of yourself, giving yourself your own medication, having your behaviors monitored so that they know that it's safe to send you out. Intensive outpatient programs, these are community-based, same sort of aspect but within the community. Guardianship has to do with appointing someone to make maybe financial decisions for the person and oversee the care of that person, that they might be able to live somewhat on their own, but yet the guardian is responsible for legal issues and treatment issues for the patient. Community outreach programs. Here the person would engage a person with mental illness and needed services. And also multi-service centers, again, outreach programs for patients who are seriously mentally ill within the community but are not housed in hospitals or institutions. With seriously mentally ill, we said 60% have some kind of substance abuse issue. Therefore, there are those dual treatment programs where people can come for substance abuse counseling and maybe methadone program or some kind of program to help them to feed their addiction without making them dysfunctional in society. They go on into evidence-based treatment programs, assertive community treatment. That would be where they would be, the patient would be monitored on a very close basis, and hopefully if there's a crisis that arises, there's a treatment team that can make adjustments or interventions to keep the patient out of the hospital through assertive community treatment. So it's a dedicated treatment team that monitors the seriously mentally ill with the hopes of providing intervention for those so that they can stay out of the acute care facilities. Cognitive behavioral therapy, I went over that very quickly, and that's just simply, the negative self-talk, capturing those negatives and putting them into positives, and that can be done with some psychotherapy, supportive psychotherapy if need be. Cognitive enhancement therapy is very interesting. I haven't looked at that a lot. It has to do with the thought that our mind is, still malleable, and that we can maybe work areas of our brain that are weaker than others, or maybe strengthen areas of our brain and our cognitive thoughts that are stronger. And this is done through computer programs and making our ability to think and relate more effective. So I'd like to do some more reading on that. So that is what cognitive enhancement therapy is. Family support and partnerships. Here it just talks about NAMI and other programs perhaps within a community where we can learn what is wrong with loved ones that we might have that are seriously mentally ill, and be able to cope with that and be supportive of that. Social skills training is very important for people who might suffer from some paranoia, perhaps think of someone on an autistic spectrum. Very successful if you can get those people and help them with their social differences, learn how to behave and act around other people. We talked about supportive psychotherapy. Vocational rehab and related services is another wonderful program where people with serious mental illness can be placed in different forms of work to keep themselves busy and to provide some socialization and to help them with feeling confident and their self-concept and self-esteem. There at Osawatomie, we went to the cafeteria or the little canteen, and that was a clubhouse model that they have there. But there's other programs within our own communities where we have workshops, or perhaps they have the ability to put someone that's a little bit more functional into a business and to have a coach with this person and allow them to be trained and do some modeling. I know that they do that in the bigger cities with the modeling of how to behave in a work situation, how to arrive on time, what the expectations are, how to behave around customers, good, things like that. So those things actually do exist and are very beneficial for people who are seriously mentally ill. Advanced directives for the mentally ill, I think I touched on that with some of the legal issues or aspects. It's just basically a directive that says, in the event that I have a relapse and can't make decisions for myself, this is what I would like done, how I would want to be treated when I can't make those decisions. Consumer-run programs, of course, it gets back into the clubhouses, for the different businesses and socialization for the mentally ill. Wellness and Recovery Action Plan. Here we are empowering the mentally ill to help with the treatment plan. I think Bonnie touched on that a little bit with the one patient she talked about previous, bringing the patient in, developing a wellness recovery action plan. Very important to remember that even though the brain is the organ that the mentally ill person is having difficulty with, it doesn't mean that they can't think for themselves. They talk about technologies and able to get help with cell phones, text reminders for appointments, and taking medications and just checking on people. Exercise is very, very, very beneficial to the seriously mentally ill. For those people who suffer side effects from their medication leading to weight gain, heart disease, diabetes, it can be a journey to health promotion and hopefully wellness, staving off those horrid diseases. It can also be utilized to just get the endorphins going for those people maybe suffering from major depression that's refractory to the antidepressants. There have been studies to show the outcomes of people taking antidepressants and the people who are just doing health promoting type things, stress reductions through maybe meditation, yoga, good food, good sleep, good exercise, that can be just as beneficial as medication. Focusing now on the nursing process, I would live here for a little bit before you take your exam. It tells you what we are to assess for the seriously mentally ill, risk of harm to self or others, depression or hopelessness, relapse signs, and there's a great sign and symptoms and nursing diagnosis, I would live there, chart 31-1. Physical and health problems, comorbid illnesses. Then it gives you a great summary of interventions for the seriously mentally ill, and I will just read them to you if that helps at all. Empowering the patient, emphasizing quality of life, developing and maintaining sustained therapeutic relationships, providing supportive psychotherapy, aiding effective reality testing. For example, if someone's paranoid, teaching them to maybe, have a person that they trust and bounce off, am I seeing things? Am I hearing things? Is this what this person really means? That goes back to the social training with people who maybe are on the autism spectrum as well. Is that what they mean? Did I behave okay? Am I focusing too much on this or that particular topic? Am I monopolizing the conversation? And the book talks about the paranoia as well. If I can see that everybody else thinks things are fine, then what I'm seeing or hearing or the suspicions I have are probably not right. And then to go one step further, and they can even ask someone if that's the case. Stigma, recognizing that it exists and how they can respond to that. Support groups, encouraging those, involving them in those, maybe even leading one of those if you're a basic mental health nurse or a nurse practitioner. Educating consumers, psychoeducation is very important, caring for the whole person, and that would be their physical, spiritual, psychological, psychosocial needs. They just go into some of the current issues in mental illness. One thing I see that's huge right now is the trans-institutionalization. We are trying to figure out where we can house these people safely. And that's huge in this chapter with serious mental illness. You have got to admit, there are just some of those people that are never going to be well. And there are some of those people that don't have the family support or the ability for their families to house them. What are we going to do with these people? It's so dangerous to keep them on the streets. It's so dangerous for them to have to cycle through the jails again. It's so inhumane not to provide some kind of stability for them. And so that's what's happening up at Osawatomie, and that's what's happening within our individual communities. What do I want you to know from this chapter? I will focus on the fact that it's a problem, chronic mentally ill people, having a chronic mental illness. I will focus on what puts them at risk. What is the difference? I will focus on what kinds of services are now available to them so that we can stabilize them and keep them in the communities and keep them as functional as possible. I will also focus in on that nursing process. When I have a seriously mentally ill come to my clinic, what am I going to evaluate that patient for? What are their thoughts telling them? Are they going to harm themselves? Or are they going to kill someone else because they're delusional or they're having hallucinations? Do they have running water, just the basic necessities of life? Are they on their medications? Are there side effects to those medications that I need to be concerned about? How are they functioning? How are they getting along? Are they being socialized? Are they social? Are they able to connect with people? Because that may lead to relapse. And then those interventions that were so wonderfully outlined in this chapter. I honestly do not see any reason why any one of you should have any trouble with this chapter and test bank questions. The nursing diagnoses, now I have seen a couple of you on tests have struggles with that. Look at that chapter, that table 31.1. Look at that and kind of see what the signs and symptoms are, what the nursing diagnosis would be for those, and then the outcomes. I think that this chapter will help people who are struggling with that differentiate between what is the priority nursing diagnosis. Thank you, and I hope you have a nice evening.